and what happens to our practice post this lockdown and post the the disease once we find a cure or a vaccine for it. So we need to understand what fundamental principles we need to follow to get back to our practices and how we can prevent further infection spread and what are the changes we need to make. So most importantly, let's look at our profession, and our goal for this presentation is to gauge and take a deep dive into our profession and see what all we can accomplish, what all can be done to safeguard the patient, the doctor, the staff, and all the ancillary people that are entering our practices. More importantly, after the pandemic, when we get back to our practices. We all know that dentistry has been always in the forefront when it comes to laying down protocols. And in challenging clinical situations, we've all been dealing with blood-borne pathogens for several years. We are all aware of the HIV and how we have overcome that in our practices. Let's not have another situation like what we had with Dr. Dave Acer in Florida. So if you look at the pandemic at this moment in time, it's around 1.7 million people who are being infected, and there's more than about 100,000 people who have died. So these are large numbers, and the global pandemic, these are figures as of yesterday. So what is a pandemic? It's an outbreak of a disease that occurs over a wide geographic area and affects exceptionally high population and proportion of people. So this is, presently we are dealing with the coronavirus disease. Coronaviruses are not new to our profession. However, this novel coronavirus, or the SARS-CoV-2 as we call it, or 2019, or the COVID-19, is something that had started in China, in Wuhan, in December 2019, or maybe earlier. We are not aware of that. However, it was disclosed to the rest of the world on the 31st of December 2019, where a lot of people were having symptoms very similar to SARS and MARS, which are established diseases which had their own cycle over the last several years. And let's understand what we are dealing with. What are the symptoms? There could be fever, a dry cough, shortness of breath, and difficulty in breathing. These are the things that we need to watch out for when we have patients coming into our practices. Less common symptoms may include diarrhea, aches and pains, and running nose. So it is not very different from, say, a regular flu. However, the pathogenesis is different, and also the mortality rate is much higher as compared to the other viruses that we are dealing with. So we need to follow fundamental principles of good hygiene as laid down by the CDC, WHO, and what we already do. We have to wash our hands frequently, maintain a social and a physical distance, avoid touching your eyes, nose, and mouth, practice respiratory hygiene, which means if you are coughing or sneezing, you need to put, some sort of a barrier. More than likely, you would use a disposable paper towel, and then you need to toss that into a bin which has a cover. So you cannot put that same barrier back in your pocket, because then you are actually the virus can remain vital for several hours, and we will go over that. If you do get primary symptoms, you should see medical care immediately and stay informed and follow advice given by our healthcare providers. So it's important to understand that. This is a slide from the CDC, and this is what we are going through presently worldwide. I mean, it's not only in India. but worldwide. So this is what is called social distancing. I beg to disagree. We are not socially distanced from each other. We are very, very close to each other socially. We are chatting. We are on WhatsApp. We are on Facebook, emails, and platform like what we are doing today, Zoom. So this is more like physical distancing and not social distancing. So I think we need to correct that statement a little bit. However, the purpose remains the same, and we need to make sure that we are not spreading the disease from person to person through small droplets which could travel far distance. It is basically through coughing, sneezing, exhaling, or touching something or someone. Currently, the estimated incubation period is between 1 and 14 days, and most commonly you would start seeing symptoms in about 5 to 6 days. Within a week, you would start to see symptoms after the first exposure. We also need to consider the older population and people with pre-existing diseases and medical conditions. They appear to get more serious illnesses. People who are immunocompromised, people who already have COPD or lung disorders, or people who are on cancer therapy. So it seems that they seem to get more severe symptoms than maybe a regular population. Initial mortality rate in the first maybe 6 weeks was only about 2 to 3%, but the percentage is now increasing, and I think it's now the hub is moving more towards North America, and it is actually moving from the east towards the west. We saw a real surge in the numbers in Central Europe, and now it's all more towards North America. So according to the CDC, close contact for healthcare exposure is defined as following. I mean, you being in close proximity, about 2 meters or a 6 feet distance with a person who has already had COVID-19 or has symptoms, or having unprotected or direct contact with infectious secretions and excretion of the patient who's been coughing. So that's very important. It's also important to understand how I keep my dental office safe. And I think this presentation would also translate very well to our colleagues who are working in the field of ENT and ophthalmology as well, because they also work very, very closely with their patients. And especially in ophthalmology, when they're examining at the slit lamp, I mean, they even are closer than the dentist. So I think the barriers are very important. So I think these guidelines would also translate very well to our colleagues in different healthcare settings. So how do I keep my dental office safe? I mean, we know things that we touch frequently, the doorknobs, light switches, cabinet handles, the front desk area. We need to wipe these, and we will talk about how to maintain these as we go over the presentation. First thing we need to do is to offer hand sanitizer to our patients at the front desk. So that's the first and most important thing, that their hands should be completely sanitized. Preferably, all public areas like toilets should be closed for patients, unless it's like an emergency. Patients should be pre-screened over the phone for symptoms. Symptoms like fever, cough, shortness of breath, things like that. So if you follow all the CDC infection control recommendations, which are there in any case for our other diseases, which could be bloodborne or airborne or secretion-borne. So we need to always understand that we need to wear our PPEs, which are the personal protective gear. And a little bit on that as we go on deeper into the presentation. And very important, we also need to protect our dental labs by disinfecting our impressions. Okay, so we have. Can we just mute?
You have to, Dr. Ashish, have to mute all the participants and admit all new participants.
Okay, I'm not able to do that from here. I don't know why.
So just click on the participants below.
No, it's not happening. I'm okay. I'm not able to get that.
Once you scroll down, you can see the participants.
No, I'm not getting that screen. I was trying that earlier. Anyway,
So you have to admit the new participants also, otherwise it will not be.
let's see if we can do that,
The
because
participants below, right below.
see, it's disappearing the screen.
So
You can ask everybody to mute themselves.
So what will happen? Any new participant will come in, automatically it will be unmute.
Doesn't matter. Let's go on and see if we can. Jay, if you can just kind of allow the new participants to come in.
Come in.
I'll have to
Yes.
ask my son, because anyway, so we have to screen our patients. Just allow all the new participants. We have to screen our patients over the phone and make sure that they have not traveled overseas. I mean, few weeks ago it was China, but I think it could be worldwide right now. So we need to make sure that we are very aware of the situation as per the spread of the pandemic and their travel history, history of fever, history of any cold or cough, and the symptoms that we've already discussed. So and then always wearing a PPE, that's important. uh, so in terms of patient control, we need to minimize the chances of exposure, instruct the patients to call ahead and reschedule or schedule our appointments. It's important that we are only taking care of emergency dental care at this moment in time, and not doing our routine procedures. We don't have to be proving ourselves to anybody, because I think it's not only important for you but also for your family. When you bring your disease back home, it can affect anybody who's there in your family. So in spite of taking all precautions, since we don't have any major protocols laid down, concrete data, and we don't have a vaccine, so it's very important to try and prevent this disease from spreading through our profession. One important thing is that our barriers like face masks will now be substituted with respirators, and we will talk a little bit about that as we go on. So there would be a paradigm shift and a shift of standard between what we have been doing earlier and what we will be doing in the future. So the mask, as I said, would be now replaced with a respirator, and there is a clear difference in the two. This is from the ADA OSAP website, and it just clearly says that the mask is actually to protect the mucous membrane for coming in contact with other parts of your body. However, a respirator has got filter particles which prevent the particles to reach your lungs. So at this moment in time, the N95 respirator seems to be the most popular and most proven right now to fight uh, these diseases. However, the N95, we'll just go over a presentation how to wear a mask properly, and then
the N95 mask. Step 1. Wash your hands before putting on the mask. Step 2. Select an N95 mask that fits you well. It's available in different sizes and models. Step 3. Hold the mask in your hand and place it firmly over your nose, mouth, and chin. Step 4. First, stretch and position bottom band under your ears. Then, stretch and position top band high at the back of your head. Step 5. Press the thin metal wire along the upper edge gently against the bridge of your nose so that the mask fits nicely on your face. Step 6. Perform a fit check by breathing in and out. While breathing out, check for air leakage around your face.
So this video is from the Singapore Health Society. It's a public domain video. In fact, Most of this information which I have collected today has been researched over the last 4 to 6 weeks, and I've been really lucky to have contacts with my friends overseas, and they've really been helping. Dr. Raghu Potaya is one of them. He's been in touch with me, and he's going to be our expert panelist today for the question and answers. He's working very closely with the U.S. government, and I think he's already online. So we will get him on when the question answer session comes. So it's important to wear your mask, and I think if the mask is not fitting well, there is more of a chance that you are fiddling around with your face, and more chance of infection spreading to a healthcare worker. So it needs to be really well fitted so that you don't move it around too much and you don't have spaces in between your mask and your face. The N100 mask, we had a discussion yesterday in a different group, and it seems to be working better than the N95. If you look at the swaging on the N95 mask, there is areas which can be left open, so there is possible entry of the viruses or the aerosols which can get in. Whereas the N100 mask has got these disposable respirators, and it seems to have a much better and a compact fit. But at this moment in time, due to the shortage of any sort of a mask, I believe that N95 would work, because N95 itself is available in a very short supply in worldwide rather. The other thing is to protect your mask from splashes. So the CDC is recommending to use either a surgical mask on top of your N95 so that it doesn't get very moist and it doesn't get spoiled by splashes. And what you could also do is wear a face shield, which we have been working on internally and at our center, and we can talk about that as we go on in the presentation. So this is what I have been able to do at my practice. This is and the NextDent 5100 3D printer. This is a time-lapse video from our own production. So we are making custom-made masks which will have disposable respirators which can be clipped on from one patient to the other, or you can use any sort of a barrier membrane. So these have been now fabricated. It takes about 3 to 4 hours to manufacture one of them. This is in 3 parts. This is the mask frame, the respirator, and then this will get sandwiched in between, and this is the holding frame. And then you can use this mask over a period of 3 to 4 months. It doesn't really get bad. It's a biocompatible material, and you keep changing these respirators. So I think the time will come where you can custom make this for your own fit, and you can actually do some border molding with a monophase silicon and then scan it and 3D print it. So it can be done. We are working on various aspects. I did get some press coverage on this. Recently in the Hindustan Times, we are making some headway on that, and my nephew is also working on the face shields at this moment in time. So during this lockdown time, we need to be a little more innovative and start working for our profession as well. So what are the ADA recommendations for the lockdown or for your practices? Right now, they are only recommending emergency dental care. Obviously, during this time, we cannot abandon our patients and say, okay, we are closed down, because the patients have been very loyal to us. So it is our duty to make sure that they are alleviated of any pain or any discomfort which is there. So we need to make sure that you are opening your dental clinic at a certain point in time for these emergency patients. Or what could be done as 4 or 5 practices could work together and have one center open in a week for a few hours, so that the PPEs and all the infection controls can be controlled by that one center. So it's time to work together, and take care of the emergencies rather than, abandoning our loyal patients. Here's a list of the emergency procedures. I mean, we don't have to really go over this whole list, but we are all aware if there is inflammation, pain, pericoronitis, cellulitis, or fractures, things like that would definitely come under uh, emergency dental procedures. And similar guidelines have been given by the Center for Medicare and Medicaid, and the use of PPEs has been recommended for each and every provider. If you look at the Canadian Dental Association recommendation, it also has a very, very similar trend. So they are all suggesting for the next 3 to 4 weeks not to do regular dental practice. And I would actually take this to another level and say, we have to make sure that we are safeguarding ourselves and our families. So it's important to be very, very careful and try and do only the procedures which are very essential for this moment in time. So if you look at the COVID-19, it's not only that it is pandemic or it's in the air or whatever, but the virus itself has a survival rate of several hours to several days, depending on the media it is sitting on. And top of that would be our aerosols, and it can be alive in the aerosol. It could be detectable in the aerosol for up to 3 hours, which means that when we are practicing in a closed chamber, we do have aerosols around us. So and it would fly everywhere. So the particle size is very small, and it has been detected on cardboard for up to 24 hours and on plastic and stainless steel or metal surfaces for several days, 2 to 3 days. So that actually is data from NIH and New England Journal of Medicine from last month. So we need to be very, very careful as to how we approach our infection control. And this is another paper from Lewis et al. And it says that it is going to be in aerosols for hours. And I was reading a report this morning, which was there in one news channel, that it has been found in air after patients are coughing up to several meters. So, there is detection of virus. So we really don't know as to how long and how long does it take to settle, and how, obviously it's not an airborne disease that we know, but there is definitely droplets which would cause precipitation. So let's look at what is an aerosol. An aerosol is particle less than 5 microns, not 50, it's 5 microns. This one was picked up from one of the websites. And the splatter is greater than 5 microns. So there is a difference in the two, and in our dental practices, we have both. So aerosol may contain salivary secretions, nasopharyngeal secretions, blood, plaque, tooth, particles, viruses, and bacteria. And, it could be in our rooms for several minutes to several hours. So we need to understand and reduce the impact of this aerosol in our practice, and try and make sure that we have good ventilation available. And we will talk about office design and surface disinfection as we go on in the presentation. So if you look at the dental procedures, I mean, the sonic and ultrasonic scalers have the greatest source of aerosol because of, the sonic nature of vibration. And the high-speed handpiece and the air water syringe also are contributing. If you're using hard tissue lasers, that's actually a little worse according to me, because then you have the plume along with the aerosols. It could be that the plume is sterile because of the laser effect, but there is no study as of yet to see the the viability of these viruses in this plume. So you still need to take the same precautions if you're using hard tissue lasers as well. let's go with this assumption that if a surface can be contaminated, it is contaminated. Because if you have a surface, a tabletop of stone or wood or whatever, or laminated, uh, obviously you can get spills, you can get aerosol settling over there, and the virus is a little heavy. It's lipophilic virus, so it tends to settle down on higher areas a little faster. So if you do have desktops and tabletops, which obviously all of us have in our practices, we need to decontaminate this, especially after every procedure that we do. Let me just mute everybody. Okay. A lot of people have been talking about sodium hypochlorite and its effects on surface disinfection. Um, it's nothing but a bleach. It's the same bleach that is used to bleach our white clothing, the hypochlorite. It's available in India as Ala or Clorox and various other brands. Um, it is a good surface disinfectant, which has been time tested in hospitals, medical labs, offices, nursing homes. However, in our setting, I think it's going to definitely kill the virus, but it's also going to kill a lot of our equipment. And what is going to happen is it has this corrosive effect, especially if it is used in an aerosol. So we need to look into different different chemical agents which have similar action. However, hypochlorite, according to many, should not be used in our water lines, also in fumigation, because it is very, very corrosive in nature. So you may have short circuits on your chairs. You may have short circuits in your X-ray machines, and various kinds of things. So the life of your equipment is definitely going to go down, the shelf life. Also, it is very corrosive. It will kill the viruses, as I said. And if you see the MSDS on the medical products for fumigation with hypochlorite, it says, please contact the doctor if it gets in contact with your skin or eyes. So there is already a warning on that. So we need to kind of understand that this is probably not the agent to be used for disinfection. There is, however, other agents which can be used, and that's the hypochlorous acid, HOCl. It's a weaker acid, but it has a similar mechanism of action. And I had this discussion yesterday with Raghu, and Raghu will go over this in our discussion section. And we can use it in 5,000 parts per million, and it has a very neutral pH of 6.3. Which means that it can be used real time to scrub the floors, and also very biocompatible with the human skin, and not as irritating. So, and it's very cheap. So I think there is studies that have been done on the hypochlorous acid, and that seems to be working very, very well for our dental situations. And I looked at the availability of this chemical. Obviously, this is industrial grade, which is only rupees 11 per kilogram. So obviously, it is not a very expensive material. It is used also in the poultry industry and also in agriculture to wash vegetables and meat to make sure that the surface is, and it's not very contaminated. It was also fungicidal in nature to some extent. So it's important that we get a medical grade of the hypochlorite, and I have checked that there is tablets, self-dissolving tablets available, and you could just mix it in some water according to the direction of the manufacturer, and the shelf life of that would be about 2 weeks, and it's not cost prohibitive. So I think it's important to use the hypochlorous acid instead of sodium hypochlorite. Okay, so precautions in the clinic, we need to minimize the time in our waiting areas. We need to make sure that we have only selected number of patients scheduled in a day. And we need to time each of our procedures so that there is no waiting areas which are packed in our rooms. Only one patient should be allowed, and there should be no accompanying person unless the patient is a minor, where you definitely need the consent. And if more number of patients are there in scheduled and they all want to come, obviously you are very popular. Everybody wants to meet you. They want to see you. They want to get your treatment. So you should ask them to wait in their cars. And once the first patient is over, your office can send them a text message or call them for them to come in. You offer them a sanitizer. Make sure that they remove their footwear outside. They don't touch any of your equipment or the knobs or the handles. There should be a designated person who could bring them in. So it's more or less a no-touch surface kind of an entry for your patients. Another good thing that could be done is to take the payment by electronic form before the procedure, so that your payment is already in, so that you're not touching any currency notes or they're not touching your credit card machines. And if they want to do that, then you can have a contactless credit card machine. So, everything will change over the next few months. And 6 feet minimum distance should be followed, for your office staff members. And we need to make sure that we are taking a complete medical history. Again, as we talked about fever, we do measure the fever for the patients coming in with a thermoscan, but it is very deceptive. It's a very subjective thing that patients have fever, because a lot of elderly patients are on several different medications, and sometimes these medications do have antipyretic effects, and especially patients who are taking NSAIDs for joint pains or for whatever reason, they already have fever which is reduced. And this is how we got fooled by the thermoscans when patients were traveling, or the carriers were traveling in these aircraft from one country to the other, because the only benchmark at that point in time was to check their temperatures. And a lot of these people were on medications, and a lot of people did take medication with a fear of getting quarantined, and probably a lot of them did get the disease. This is how it would have happened. This is the scenario in my own dental clinic. I mean, I have a waiting area for about 10 to 12 patients. What I am planning to do is the following. Right now, this is a 4-seater and 2 3-seaters. So I would probably have one person sitting here, another here, and a third one over here. So I would not have more than 3 people sitting in my waiting room if and when I open. Also, all these extras, all these wall hangings, all the furniture, all the props which are there, they would all disappear, because we need to have clean surfaces, and we need to make sure that getting rid of all the old magazines, everything, because you would have multiple people touching them. So you need to just remove everything from your waiting areas. The zone of contamination would be over here, because a lot of patients would lean over when they want to do their payments, or they want to speak with the staff, or they want to reschedule their appointments. So I would probably put a 6 feet tape over here, and then they can actually communicate from a distance. I would put some sort of a plastic barrier over here with a little peekaboo cutout for payments or whatever if needed. However, we are now encouraging apps like Paytm and Google Pay and direct bank transfers for all our patients. So I think it's important to handle. It's important to handle this in a very structured way. Again, from a point of view of your clinical situation, this is the amount of spread of the virus that can occur with all these aerosols. We need to get rid of a lot of stuff from the countertops and make sure that we are putting some HEPA filters as air purifiers. And in fact, I had this discussion with Raghu yesterday, and he was saying, why don't we have an outdoor dental clinic where you have everything open to air, and there is no there is no chance of an aerosol going on any surface. Maybe that would be a thought. We can prepare some tents and start doing it, just like the warfare. So, it's food for thought. And but I think in the present scenarios, to retrofit everything into our practice is going to be a big challenge, because we already have a lot of things which are fitted, and we need to make sure that things are disinfected. So the good news is that Henry Schein has announced the availability of the coronavirus point of care antibody rapid test, which is now available to the healthcare workers. So this is now starting as of next week. There will be kits which will be available, and so you can get yourself and your staff and your patients tested, and I think it will become a standard of care. So the standard is to do the IgM and IgG rapid testing. We'll go over what this testing means and what kind of tests are being done for our patients, and how to avoid getting false negative results and so there is a timing for each of these tests to be done. So it's important to understand when the patient has symptoms and when the test can be done. So this is a small video about the testing from Henry Schein. Very informative.
Hello, I'm Dr. Michael Kakar from Rochester, New York, where I'm a specialist in respiratory infections. Testing is important because we're trying to triage cases.
It's very important to understand who is ill and who is not. If we don't have access to proper testing, the truth is we don't know how to properly treat, diagnose, or screen the patients that we're dealing with at the front line. It creates a lot of anxiety, concern, and uncertainty about where things are going and how we're going to be able to treat them to make them get better.
There are three types of tests: the PCR test, the antigen test, and the blood test or serology test. The PCR test, that's where you take a nasal swab, deep into the nose or the throat, and then you process looking for a molecular evidence. PCR test is best before you even have symptoms. You can detect the virus with PCR, and it's still there and easily detectable in the first week to 10 days of the illness. That's test number one. Antigen test, also nose swab or throat. There you're looking for the coding of the virus as being detected by a laboratory test. By 2 weeks into the illness, the PCR test is going down. The antigen test is really not reliable until you start to have symptoms. And by the third or fourth or fifth day, as the symptoms are going up, that's when the antigen test really works best. And the third test, serology test, or blood test, this is looking for immunity to the virus. It takes about 10 days for your body to make the first response of immunity that we can detect in your blood. And that's called the IgM test. And then about 2 weeks or 3 weeks later, we can detect it even better with another serology test called IgG. IgM is the first antibody response. We normally can detect that somewhere between 10 and 14 days after the onset of an infection. So the next window of time we look at is maybe around day 21 to day 30. Now the IgG is much higher than the IgM. At that point, you probably won't detect any IgM, but you see a sky-high IgG level that tells you, okay, the maximum immunity response has now been measured.
Generally, when you build up an antibody resistance, it means that you were protected from getting the worst case scenario of that illness again.
With a PCR test, doctors cannot do that in their office. It has to go to a hospital or to a laboratory. Whereas the antigen test and the serology test, those tests may be possible in a doctor's office or in an emergency room or urgent care setting. However, be careful. As these tests become available, you want to have something that is FDA approved or has been approved under an Emergency Authorization Act or some type of a waiver.
The most important thing for us is accurate, reliable, and factual data.
We're anxious too, but we're doing our job.
If we didn't have nurses and doctors on the front line, they were too scared to go to work. This crisis would be 100 times worse.
We want to know if we've contracted the virus so that we can then avoid giving care and being contagious to others. And if we do become immune, we want to know that we're immune and we can return to work and we will be able to provide care over the long term.
Today's times are unlike anything I've ever seen in healthcare in my tenure, and I am concerned that until we accurately diagnose and test the significant number of cases that we're seeing in the United States today, we're going to have a significant struggle to be able to support those who are currently on the front line.
But right now, what we want to do is make sure that our essential providers, healthcare workers, firemen, policemen, those first responders, that we're giving them the support and access to testing that they need for themselves in order to provide protection to the public. We also will be giving that information to our local hospital epidemiologists so we can track this pandemic across the United States.
Good. So we now know about the testing, and we need to then do a risk assessment for our patients who are walking into our dental offices. You know, if we do have the test available, I think that is the more important part. So we need to, this is a simple flow chart, and you know, I can share all these slides with you on an individual basis. My email, you can email me, and I think we should use it more and more for the betterment of our profession. And these are slides all from public domain, most of them, and I've just been researching a lot in the last few weeks to get put this presentation together. So this flowchart would actually give us a clear idea of green, amber, and red, where we have to take certain precautions for all different kinds of patients. So testing, I think, is the most important part for safeguarding the healthcare workers and our staff over here. So what we want to do is we want to make the dental clinic as a safe place for every patient, for every visit. We need to make sure that the confidence of our patients is back, and they should not relate it to all what has been happening in the past, like Dr. Acer's incident that I talked about, who was spreading HIV. So it's important to upgrade our practices, because things will not be the same. Our practices are going to be completely different. The way we structure our practice is going to be different till we find a vaccine for COVID-19. I was looking at the ultraviolet situation, the International Ultraviolet Association, specifically at about 260 nanometers. It tends to activate the SARS-CoV-1 and the MERS-CoV. So this is the same family of the viruses as the COVID-19, and there is enough evidence to show that the ultraviolet lights at this wavelength, 260 wavelength, seems to inactivate or kill these viruses. So the effectiveness of these lights for COVID-19, we don't really know, but in conjunction with our other measures, other chemical disinfections, the HEPA filters, maybe high evacuation systems, which we'll talk about very quickly after this. So it may be a adjunct thing that we can do in our clinics to put ultraviolet lights, and maybe we can leave them on overnight so that we have some sort of a disinfection which can happen. And these are really cheap. These are not expensive lights. However, having said that, they can be very harmful if you are working real time under these lights, because these have shown to cause skin cancers. So there is a fact sheet available on the International Ultraviolet Association's website. So I would encourage you to just read that. It's a one-page document. It's very simple, straightforward. This is something interesting that I received from a colleague in Poland. So this is what they have done in their practice. So what they've actually made a tent outside the practice where they disinfect their patients. So this is the area where patients can go. Beyond this, the parking lot has been converted into different tents. Standard precautions, thermoscans, the face masks, the disinfectants, things like that are used for each entry of the patients. Patients have to remove their footwear at a certain point in the practice. They're not allowed to touch the railings. And this is what the barriers they are using. And I mean, it looks like a war zone, honestly, because that every staff has got PPE. I don't think this is necessary for our staff because they will never enter the clinical area. However, you need to provide them with surgical masks and probably have them just restricted in a certain area. So this is the 6 feet tape where this is safe distance. Over here, these are the number of masks they would use in a day, and an entry and an exit point to each operatory with plastic sheet barriers everywhere. The coffee room has been converted into a changing room in this office. I mean, and public areas like toilets and elevators. Elevator has to be operated only by one staff. The toilets are completely closed down for public use. So also personal protective equipment. There is a lot of choices which are available right now. I think DuPont makes and 3M makes the best personal protective equipment right now. However, these could be cost prohibitive for our use. So we have to look at some local sources. The idea is to have a complete airtight situation where there is no spill or aerosol that can go into our clothing or our footwear. So you need to protect everything, including your eyes and ears, and so or special kind of anti-splatter devices can be done. This is another equipment which uses a positive pressure. It's like a CPAP machine, which has a headgear, and then you have the laminar flow in between your face and the shield, so that it will prevent. It's like an air curtain with positive pressure. So I mean, these equipments can again be very cost prohibitive for our practices. Another colleague who's using a gas mask. I mean, yes, it's a good respirator, but I do believe that these are again very cost prohibitive for our patients, and then you need several of these for different operatories and your assistants. So the cost impact on our practices are going to be very, very significant if we start looking at all these PPEs and all the modifications we need to make in our practice. So if you have big rooms, you kind of should have ventilation available after each procedure, and then you can mark the safe areas, from the distances with tapes. A lot of talk about HCQ and prophylaxis of healthcare workers. So I am just putting the Indian guidelines for healthcare workers. HCQ has proven to have some effect, at least out of 2 studies that I read in the last few days. One study from France is showing 68 out of 70 patients have actually recovered completely after the HCQ therapy along with azithromycin. And there's another study that has shown that it has no effect. Having said that, we are from a tropical country. We have had exposure to chloroquine at some point in time. So keeping in mind the ill effects of or the side effects or the harmful effects of chloroquine, so keeping in mind the side effects, we should, at least as a healthcare worker, we should follow the regime which has been laid down by the Indian Council for Medical Research, since we are at high risk. And this is the regime which is there: 400 milligrams twice a day on day 1, followed by 400 milligrams once a week for the next 7 weeks. So it's very similar protocol to the malaria. And obviously, you need to see your G6PD deficiency. It's important to understand that. Otherwise, there is issues of hemolysis and other things. So you need to have all your blood work done for G6PD deficiency before you take this drug. Interesting product which has now come out in the last few days, and various companies are marketing it. This is suction with a hood on it, and it has got a very high power vacuum, and it actually goes through various HEPA filtration and some fiber and the activated carbon and the UV chamber, so that it will release clean air back into your office, and it's actually going to take all the aerosol. Uh, so HEPA plus UV light plus filter. It's what is HEPA? HEPA is a high efficiency particulate air. So you need to have a HEPA filter, and a medical grade HEPA filter or air purifier would cost close to about $2,000 US, whereas the regular air purifiers are much cheaper. But I think the HEPA purifiers is the call of the day for our dental clinics. So we need to get into that as well. So this is how the suction works. You know, you're seeing the ultrasonic cleaning being done for this patient, and then it is actually releasing all the aerosols and getting captured in the suction. As I said, the Indians are much more innovative than many other people. So this is a device which is for less than 1,000 rupees, and these are basically hollow pipes which can be connected to your high vacuum suction, and then you can actually work in this closed environment and keep changing the cellophane sheets between patients. It looks simple, but I think it would be worse for our patient because they would feel that they are in an MRI machine. So it may not be the ideal thing, but till we get something, it's something that can be considered for our practices. The only issue would be the direct field of vision would be very, very hampered. So having said that, I would like to close this presentation. I'd like to thank you all for your attention. And we do have time for some question and answers. And I think Raghu is already there. So along with him, Dr. Paul Graziosi is also there from New Jersey. And we've all been doing some study together on the prophylaxis for this disease, and we will try to answer your questions. I'd like to acknowledge the contributions from the following websites, and it's the ICMR, Center for Disease Control, American Dental Association, the UV Association, and OSHA for Dental, which is there, and Henry Schein, because there is a lot of things that, a lot of information which we have been able to pick up from these websites. So moving forward, I think we need to do these, incorporate these changes into our practice. Life is not going to be the same what it was in the field of dentistry. I don't know how the institutions would carry this forward, but I think we are at the top of the pyramid in terms of being infected from a healthcare point of view in our profession. So I'm just going to bring Raghu. Are you there? Can you?
Yeah, I'm here.
Okay.
Can you hear me?
Yeah, Raghu is there. So and Paul, are you there? Dr. Paul Gradfield, are you there? No, I think he may not be there. But Raghu, what is your scenario right now in the US, and how are you handling it for the government, and what are the guidelines that are being thought about?
Okay. For over 2 weeks, we're pretty much under a similar situation as in India, except people are allowed a little more easily to go, at least in Texas. A lot of other cities, they're pretty much what India is going through. And in the US, we are not considered essential per se, other than for emergencies. So